Welcome, everyone. My name is Karen Lee, and I would like to welcome you to the California Improvement Network, or CIN, webinar called Streamlining the Referral Process, More Efficient Care and Improved Patient Experience. Just a bit about the CIN. It is a partnership between the California Healthcare Foundation and 8 partner organizations around the state that support spreading improvements in chronic disease care. We host these monthly webinars on timely topics related to improving clinical quality, patient experience, and/or reducing the cost of care. We're anticipating several more people joining the call, and in total we expect a large audience, so everyone has been muted. If you would like to ask a question, please send me them through the chat function that is towards the bottom right part of your screen. We are planning to most of the questions will be addressed during the Q&A towards the last 15 minutes of this hour webinar. I'm delighted to introduce our speakers today, Drs. Alice Chen and Alan Glasseroff. Dr. Chen is Medical Director of the Adult Medical Center at San Francisco General Hospital and as an Assistant Professor of Medicine at the University of California, San Francisco. Her work has focused on creating policies and programs to improve access to and quality of care for underserved communities. She has been instrumental in the local implementation and national dissemination of the UCSF SF General e-referral model, which she'll be speaking about today. The e-referral model has received awards from the San Francisco Health Plan, the California Association of Public Hospitals and Health Systems, and the National Association of Public Hospitals and Health Systems. Dr. Alan Glasseroff is Chief Medical Officer for the Humboldt IPA, which is also one of the CIN partner organizations. He maintains a part-time private practice in family medicine as well. He is co-director of the Aligning Forces for Quality Humboldt Initiative and was the principal investigator for the Humboldt Diabetes Project. Dr. Glasseroff has served as faculty for diabetes collaboratives for a number of organizations, the California Academy of Family Physicians, and Breakthroughs in Chronic Care program, and for the Institute for Healthcare Improvement. For the Institute for Healthcare Improvement, he has consulted on various projects, and he also sits on the board for Lumetra. He is a CHCF Leadership Program alumnus and served as president for the CHCF Leaders Group for 2006-2007. So without further ado, I will turn it over to Dr. Chen.
Great. Thank you very much. Let me see if I can. Great. Thank you for having me. I'm really excited to see that there's such a broad range of people who are interested in this issue of primary care, specialty care processes and streamlining the process. I'm just going to jump right in. Unless you are from a well-integrated healthcare delivery system, your primary care, specialty care, referral, and collaborative process is probably paper, telephone, and fax-based, which leads to a clerical rather than clinical process of having the first person who comes in be the first person who's scheduled without any real attention to clinical urgency. Speaking for our system, but again, hearing from many others who experience the same thing, there are significant inefficiencies. Primary care providers who are referring to the wrong clinic, not knowing that someone who I'm referring to endocrine clinic should actually be going to diabetes clinic, unnecessary referrals that could have been preempted by management in the primary care setting. For example, if I don't know what to do with some basic thyroid function test, and the endocrinologist could have given me some advice and forestalled that appointment entirely. Premature referrals, where they do need to see the specialist, but again, that first visit would have been better spent not filling out a form or ordering additional tests. Inability to discern the referral question, which surprisingly happens not just in safety net settings, but across private settings, in part because many of the times the specialist actually doesn't receive any information at all from the primary care provider. And I mentioned already lack lack of equitable triage. So in our system, this is an example of a best-case scenario where the referring provider filled everything out, sent it over, it was received, the patient was scheduled, the patient showed up, the referring provider saw the patient, scribbled something back, and sent it back to the referring clinic. And as you can see, I don't even need to block anything out for HIPAA purposes because most of it is illegible. So in our system, we really asked ourselves, is this really the best we can do? Before I get to what we did, I just want to explain a little bit about our setting, which is based in San Francisco. The San Francisco General Referral Network. So San Francisco General Hospital serves as a primary provider of specialty services for the uninsured and many of the Medi-Cal patients across the city. Inside the box, you'll see what's considered DPH, which is Department of Public Health funded clinics, what we call community-oriented primary care clinics out in the community, some hospital-based primary care clinics, and then outside the box are partner clinics, which are organized under the umbrella of the San Francisco Community Clinic Consortium. And altogether, San Francisco General provides over 500,000 ambulatory visits a year. Of those, about 29% are specialty care and 20% are diagnostics. I think a really important thing to note about our system is that we have salaried specialists. So these the specialists who see all these patients are UCSF faculty who have annual salaries that are not dependent on volume. And the other really important thing to know is that over time, we've developed relationships where not only the DPH-funded clinics, but also the consortium clinics have access to the San Francisco General EMR. So there is common access. It's not great access. It's getting better, but it is access. So what we decided to do, in part because given that we're a safety net setting, our wait times for some clinics had ballooned to about 11 months for the next routine available appointment. So the chief of our gastroenterology division actually wanted to develop a streamlined referral system. So we developed eReferral, which is HIPAA compliant, web-based, separate standalone program, but it's very tightly linked to our EMR, which allows auto-population of relevant data, not just provider and PCP data, so I don't have to write in my pager number and my phone number, but also patient data, demographic data, and clinical data, so laboratory and radiology tests. We opted against expensive guidelines, and we went for free text referral questions, and you'll see an example of this in a second, and it was mandatory. So if a specialty clinic decided to start using eReferral, all of the clinics, whether you were consortium or DPH, had to use eReferral. The main thing is, however, is that this is not IT for IT's sake. This is IT to support a new model of care, which is that I, as a primary care provider, make a referral, and there's actually a live person on the other end who's actually reviewing and responding to each referral. For the medicine subspecialty clinics, we have physicians. For surgical subspecialties, we have NPs. And the idea is that you can communicate back and forth to clarify the question, to ensure that the pre-workup is complete before the patient shows up for an appointment, or sometimes the patient doesn't need an appointment at all because it's taken care of through this process. So let me walk you through a schematic. I submit a referral. The consult is reviewed electronically by a specialist, a centralized queue. They log on, most of them log on almost every day. If it's appropriate and the pre-referral workup is complete, and if it's non-urgent, they put it in a queue for the clerical staff to schedule for the next available. If it's urgent, they indicate that they should be overbooked. If the PCP can manage with guidance, or if the specialist reviewer feels like the pre-referral workup is incomplete, it's not scheduled, it goes back into my queue. I'm the PCP, my queue, and this can go back and forth as many times as needed. And of those, some are eventually scheduled and some are never scheduled. So let me just share with you a little bit about the impact of our system. Clearly low-hanging fruit, elimination of illegible faxes, but it actually had a profound impact on wait times, which is one of the central drivers for us in terms of the mismatch between demand and supply of specialty care. And then clearly we have an ability to triage urgent cases, advise, avoid unnecessary referrals, and then we've also documented significant improved efficiencies in specialty care. So you saw the best case scenario before, and this is what it's been turned into. And what you can see is that, again, all of the information between the black bars is auto-populated. I did not have to enter any of that in there. We've actually added pictures. This was a later development. We're constantly tweaking our system, and we decided to add pictures of the reviewers and the primary care providers so that people could actually make even more of a connection across a fairly dispersed system. And you can see my initial referral was at the bottom, and then there's a back and forth that's all date and time stamped, and it's all legible. And it's all actually part of the medical record in real time. As soon as I submit a new referral, anyone who logs on to the EMR, if my patient shows up to the ED in 2 hours, they can actually look in there and see what my referral was. As soon as the specialist responds, anyone who has access to the EMR can see that response. This is an early graph of some of the impact on wait times, and you can see that for almost all of our specialties, we had significant decreases. These are for new appointments, the next available new appointment, anywhere between 30 and more than 100. Actually, this is about 30 to 50% decrease. We've had other clinics where it's been almost an 80% decrease in wait times, and cardiology is actually our one clinic where we actually lost specialists, which is a confounding factor here. This next slide, let me just walk you through this, is data about all the referrals that we received. So on each row is the clinic. The next column is the average volume of referrals per month. So you can see we're not a very large system. There's systems like Chicago or LA that would just look at this and say, oh, that's probably a week's worth of referrals for them. The next three columns, scheduled initially, overbooked initially, and not scheduled, add up to 100%. So what it does, it gives you a breakdown of what percentage. So for cardiology, 53% of referrals were scheduled on the first pass. 24% were actually scheduled sooner than they would have otherwise. So this is our triage function. And then 21% were actually not initially scheduled for a variety of reasons. The next two columns in blue actually are a breakdown of that third column. Of those that were not initially scheduled, 5.7% for cardiology were eventually scheduled, and 16% were never scheduled. And then the missing is basically we've had to is a function of our database. So you can see again here, the overbook column is a triage function, and anywhere between 1 and 36% of our referrals were scheduled sooner than they would have otherwise. And partly you have to, I'm sure this is apparent to you, the longer the baseline wait time, the higher the likelihood that you'll have to overbook somebody. So if your routine available is in a month, you probably won't have to overbook hardly anyone. If it's 11 months, you may be overbooking almost everybody. The scheduled after additional review, we consider a saving of at least one visit because those people would have just been put in the queue and seen. And then the never scheduled are people who are people who would have resulted in at least one, if not more, visits. In terms of specialist efficiencies, we actually did a study where we surveyed the frontline specialists in clinic who were seeing the patients who made it through for an appointment. So again, this doesn't take into account people who were never scheduled. So of the people who ended up in clinic, we asked the person who is seeing the patient who is not the specialist reviewer. So again, this is a different person. You have a centralized reviewer, and then you have specialists in clinic seeing the patients. How difficult was it to identify the reason for the consultative visit? I mean, I'll tell you, especially at San Francisco General, where we have a lot of low literacy patients, and about 35 to 40% of our patients don't speak English well. I've had patients go to back clinic and, or ortho clinic for their back and have their knee examined and things like that. And I think it's equally frustrating for the specialist to feel like they have no idea what they're actually trying to treat. So you can see that the problem was much worse initially in the surgical subspecialty clinics, where almost 40% of people under the paper-based system said that they had difficulty identifying the reason for consultation. In the medicine clinics, it was about half that, 20%, and for both settings, it ended up being about 10%. And what's interesting here is when I first saw this data, I thought, this really should be 0, because you're going back and forth and you have the specialist reviewer clarifying what the consultative question is. But in talking to the reviewers, there's a general consensus that after 1 or 2 passes, if you still can't figure it out, it's probably just best to have the patient seen. And obviously there are also variations among specialists in terms of judgments of clarity. So there may be a difference of opinion between the specialist reviewer and the frontline specialist. So in terms of challenges to spread, which is partly what we're here to talk about, clearly we benefited from having access to a common EMR. Now, the consortium clinics, particularly in the beginning, had a lot of challenges with this because even though they have access, they had to log in through two different firewalls and 3 different logins to actually get to our EMR, and there were real problems with connectivity and being dropped from the system, which I'll show you in a second. The second issue that I think we benefited from is having an academic environment. So we have specialists who are really, used to teaching, and this is part of their day-to-day habits. In fact, when we first started Referral, we had some of our specialist reviewers appending chapters to responses saying, well, the latest study shows this, and this is what I would recommend, and if you want a reference, here's a chapter, and we actually put the kibosh on that, and we decided, you can put in an abstract, but nothing more lengthy than that. Our specialists are salaried, so in fact, it was not difficult to get buy-in from our specialist reviewers. They are actually now compensated for the time that they spend reviewing, but in the beginning, they were as frustrated as those of us on the primary care side about the long wait times, and they felt like it was unsafe for our patients. We weren't providing good care, so they embraced the idea of being able to provide asynchronous care and providing guidance to the primary care provider without necessarily needing a face-to-face visit. And then finally, we also did a survey of all our primary care clinicians early on. And even early in the system, the vast majority of PCPs reported that e-referral resulted in better care, but it was more work. And this is from that paper that we published on this. Overall, how has e-referral changed clinical care for your patients? And what you see is that overall, 71% felt it was better, but there's a real discrepancy depending on where you practice. So 79% of those, so if you look in the far right column under better, the high column, 79, are people who are practicing at the hospital, the primary care clinics based at the hospital, versus 68% for the COPC VPH clinics, which have good connectivity, versus 50% for the COPC clinics. And again, when we dug down into this data, it really was very much about connectivity, but actually connectivity of 2 sorts. One is the actual IT problems that people are facing, but the other is the human relation part of it, where the people at the hospital oftentimes personally knew the reviewer and could felt like they were more connected instead of a person who was just manning an electronic queue. So just to wrap up, I suspect a lot of people are here because we just had a first pass at healthcare reform and a real emphasis on things like accountable care organizations and the patients in a medical home. We really feel like there is a potential for HIT to improve communication efficiency of this interface. What we like to, when we actually work on our e-referral model, when we present it to primary care providers, we really do not conceptualize it as a way to keep referrals out. I think we tried the gatekeeper model in the 80s. It was not embraced, I think, either by the PCPs or the patients. I think the real role of this kind of model is to support the primary care provider in taking optimal care of the patient. Because frankly, I think most PCPs want to be able to provide as much as broad care as they feel safe and comfortable doing, and having specialist backup is one way of doing this. And it's actually much more patient-centered not to make patients trek around and see different specialists if they don't have to. In terms of the role of the specialist, I think if you have a specialist reviewer who is, particularly if they have academic leanings and they're into evidence-based medicine, and I would make a distinction between evidence-based medicine and consensus-based medicine, because frankly, I think a lot of the specialist societies put out guidelines that they will readily admit are consensus-based and are not necessarily evidence-based. But I think if you have a specialist who is well-versed in evidence-based medicine, this is a way of standardizing and improving care more broadly. I think for groups that are thinking about banding into accountable care organizations, this is going to be a really useful tool. And frankly, being in the safety net, one of the things I look forward to is expansions of Medicaid, but I think there will be an actual crisis in specialty care. Not that there isn't one already, but with expansion of Medicaid to 16 million additional people and payment parity between Medicaid and Medicare without commensurate increases in specialty compensation, I think we're going to have a real bottleneck of people coming into primary care but not having access to specialty care. And then I just wanted to end with a list of our e-referral team just to really bring home the point that it takes a lot of people working in collaboration to make something like this work. And that's it. I think I may be under time.
Thanks, Dr. Chen. I think you are under time, and we have a couple minutes for maybe a question or two. Is there anybody who has a question for Dr. Chen?
I see a couple questions here. Should I address them on the?
Oh, yeah, they must have sent them directly to you.
Sure. So one question is, do patients receive any paper about the referral at the time of the referral? And unfortunately, I think this is one of our biggest shortcomings of this program, because in the past what happened was the patient would stay in the room and the medical assistant would call the clinic, get an appointment, and hand them the appointment date, even though it might be 11 months down the line. They left the clinic knowing when the appointment was, and they had a little bit of say, although frankly a lot of our clinics only happen half a day a week, so you don't have a lot of discretion. Right now, the patients leave and they are contacted by automated letters, and if it's less than 2 weeks away, we actually call them with an appointment. But the problem is the patient actually doesn't have there's not a lot of input about when their availability is. What we do now is we have a special field where if the patient knows that they're going to be out of the country, we have a lot of immigrant patients who decide to go back to Mexico or China for a little while, we can actually say, please don't schedule for these months, or please have an afternoon appointment. But it would be the PCP or the referrer who actually puts that in rather than the patient directly. In terms of, let's see, this is a gatekeeper model. I think I would disagree, because I think that the idea really is to support the primary care provider clinically and to enhance the PCP's ability to take care of people, the next patient with the same condition. And we're actually trying to study this now, which is if you've referred 3 people for hypothyroidism and the specialist has given you guidance on all of those, with your 4th patient, do you not even need to submit any referral, because you're actually able to take care of those patients now? And again, we really try to emphasize in our system that it is supposed to be a consensus opinion, so that if at any time the PCP doesn't feel comfortable taking care of the patient, that the specialist should see the patient. And frankly, there are some also patients, speaking for myself personally, I have some patients who are somatizing, and basically I've tried to work with them. I tell them they don't need a specialist, and they really feel like they want that one visit, and I'll actually just put it in the referral saying, I've done this workup, this is my assessment of the issue, I would appreciate one visit to assuage this person's fears. And it actually is a way for us to, again, work more collaboratively so that we're on the same page in terms of the messages that we're giving our patients. Let's see, HMO patients. So we are a safety net. We only take Medicaid, Medicare, and then uninsured patients. We do have a number of HMO patients, but they're San Francisco Health Plan patients. So there's our local initiative Medicaid managed care plan. And we do not so within our system for those patients, if your primary care provider is within the DPH system, there is no prior authorization process. If the specialist reviewer denies an appointment that the PCP feels like should be made, we ask the PCP to first contact the specialist reviewer directly. And if that doesn't work, we actually have a whole chain of command where they go to the division chief and then the service chief and then the CMO of the hospital to adjudicate.
Dr. Chen, I know that there are more questions coming in, but I think maybe if we could have Dr. Glasseroff present and then take use the rest of the time after that to take questions. Would that be okay?
Yeah, of course.
Okay. So now we are, Dr. Alan Glosseroff will speak about the North Coast Referral Network.
Hi, Karen.
Hi.
Can you send me the ball? Oh, good.
Yeah.
Okay, got it. So I'm going to tell a slightly different story that has to do with fee-for-service world, though there a little bit of HMO in a non-academic setting that is essentially a mixture of private practices and safety net clinics. And for those of you who've ever heard me speak before, a lot of the work that we do in Humboldt County is intentionally designed to try to deal with all of the patients of Humboldt County, regardless of business type. So it gives us a chance to really try to plan how care should go within a region or within a community. Specialty care in Humboldt County is there are some specialties that we're short of. There are some that we probably have an excess. There are some that have organized into what I call monopoly cartels within a single specialty. But it's far from the environment that Alice describes, where ideally primary care is at the front line and the specialists are actually hired to teach and be helpful to primary care. While we do have that, it's more based on the personality of the individual. But the business model here is seeing people, because that's where procedures come from, which is really the revenue source that most of the surgical specialists care about, or consultations, which is what the cognitive specialists care about. So it's a slightly different atmosphere. The story actually starts in the same place because a few years ago, the California Healthcare Foundation put on a conference in San Francisco called Better Ideas in Chronic Care, and I think it had to do with putting them into action. And I attended a breakout session about e-referral, knowing very little about it, and Alice was one of the presenters, and I came away quite impressed with what they were doing, but unsure that there was much of a role for that in the chaotic fee-for-service private practice environment in which I lived and practiced. Fortunately, my CEO also attended, Martin Love, and he was smarter than I and realized the significance of what we had just seen, which is the story I'm going to tell today. So a little bit about Humboldt. Most of the innovation in the county has originated with my organization, with the support of the California Healthcare Foundation and more recently Robert Wood Johnson Foundation. We live on a platform of about 5 to 10% managed care, and the IPA is a delegated group in that regard. But the county as a whole includes all of our members, as the practices that are members within the IPA, including the safety net, encompass almost the entire ambulatory side of care and a lot of the hospital side as well. Our approach to IT and to work is a phrase that, based on a phrase that we got from Sam Karp at CHCF, which had to do with his conclusion after the disappointing results in Santa Barbara about a decade ago around health information exchange, that it's better to do things radically in an incremental way than single solution solves every problem. And we've tried to follow that. Occasionally we blow it and diverge onto big solutions, but generally find that small solutions work better. The idea is basically to focus on functions that increase the communication, help with decision support at both the primary care and a specialty level, make care more reliable and reproducible, have better outcomes, and then also help the patients activate, because ultimately we see our job as medical providers as we're in the behavior change business. So everything we do is trying to figure out how to change behavior. And one question I would have had from Alice's presentation is about no-shows, because one of the issues with specialty appointments is no-show, and I wonder if they're tracking that given their system. But the ultimate goal is to create a virtually integrated system of care within a culture in a rural county that's actually based on clinician autonomy. Not an easy thing to pull off. And the steps we've taken started with a diabetic registry, now called Faxes. Originally it was a different product. We then went into comparative reporting, patient experience surveying and reporting. Now we're doing public reporting of quality and patient experience. The next step we got into was this, what I'm going to talk about today, IRIS, which is internet-based referral information system, and then eventually kind of a master patient index so that we can track patients across the continuum of care and actually know who they are, because we don't have a single system of registration. So Joe Smith and Joseph Smith and Joey Smith are hard to know that they're the same people in a place like Humboldt. The partners I'll list here, but not talk about. But it essentially was a lot of the major organizations that deliver or involve with healthcare in the county. The problems are very similar to the list that Alice had with excuse me, one major caveat. Our problem is not specialists who have 11 months waits, who are not being paid to see people and are trying to figure out more intelligent solutions to speed up referral and help patients out and improve safety. More often it's that they want visits, that there are too many of them, that there are open appointments they're trying to fill, there are block times for their surgery at the hospital they're trying to fill. So often the answer on a specialty view is send me the case. From a primary care point of view, and I'll get more into this a bit later, it's sort of trying to read the tea leaves or understand an occult process to try to figure out how to actually make a referral that'll work. Because each specialist will have their own form, have their own set of rules, and may or may not get back to you, may or may not contact the patient, and it's very demoralizing on a primary care point of view to try to deal with these things. I see here I write a variety of ways to appoint patients and multiple phone calls. Well, really multiply that by 100, and you have a view of the chaos that we entered trying to make referrals in the county. From the PCP side, patients were almost never able to leave the PCP appointment with a specialty appointment at the same time, and a lot of research has gone on looking at why people no-show or don't do things, and lack of closure is a really major reason for no-show. And so the more you can have the patient walk out with the actual appointment, the more likely it is to happen. Again, the PCPs often didn't know what had actually happened, and a patient come back, see the PCP, you'd look at the patient and say, oh, did you see the specialist? They would look at you in shock saying, yeah, I saw him 6 weeks ago, don't you know? And I go, well, actually, I haven't received any results. Then you'd step outside the room and go to your front desk and say, please try to track down these results right away in the 15 minutes the patient's here. Hope that they're faxed over, only to hear, oh, sorry, that wasn't transcribed yet. So, wasted visit, angry, disheartened patient, primary care looking really bad in the patient's eyes, not a good consumer survey about coordination of care. So all of that kind of working against us. From a specialist point of view, and you talk to them, they go, look at these ridiculous referrals. I'm a cardiologist and they're sending me GERD cases. How could I possibly read this? They're not asking for anything. I walk into the visit and neither the patient nor I had any idea why the patient's there. What a waste of time. From the PCP offices, they'd call the PCP, play phone tag, not get any response back. The primary care would finally return the call. The specialist would be off on their OR day, not there. Weeks could go by before connections could be made, even clarifying the reason for a referral. And then it was not atypical that the specialists were saying they get there and there's absolutely no supporting information whatsoever. practices with EMR sort of would kill by volume. The MA in charge of the referral or the referral specialist would figure more is better than less and send over 73 pages of EHR data. And the specialist would, print this out and then try to figure out which page to read or whether to throw it all away. For things like imaging or procedures, patients would walk in for their CT scan not having stopped their metformin or glucophage, and they'd have to cancel the case because instructions weren't clear or they were not NPO for a test they were supposed to be NPO. Patients were difficult to contact. Very commonly, the primary care would finally get a note back 6 months later saying we tried to call the patient 27 times and couldn't reach them. And then authorizations also got in the way. Were things auth needed for the visit, for follow-up, for procedure, all of that, very unclear. So the solution we came up with was this IRIS system. And again, we first heard about this at the California Healthcare Foundation meeting a few years ago. But it's a system that was developed by a company called Proximare for Cook County Hospital. And their issues were very much like what Alice described in her talk, but on a scale of tenfold larger system or even more. They took a different approach. I trained in San Francisco and at UCSF and in family medicine at the General, and I know the level of training that most of the primary care clinicians have who come out, most of whom end up practicing in the city one way or another. In an environment like ours, or perhaps at Cook County, there's wide variety of skill in the primary care side, and it's not a safe assumption that the rules base that makes sense from first I did the simple thing, then I did the more complex thing, then I did the third thing, and I'm only referring after the three things failed. That exists, because often what we're seeing is referral before thought, and that was really frustrating for the specialist, and also ends up costing a lot of money. So we created a web-based and rules-based system, and that's really the thrust of what I'm going to talk about. And the rules had to be developed locally. We inherited a bunch of rules from Cook County, but mostly we've rewritten everything. So it's a rules-based system, and what that means is that if you want to order a specific test, questions come up asking you, have you done the earlier steps? Like you want the CT scan, well, have you done a pelvic exam first? Did you do a pregnancy test? Did you do a creatinine for a patient who needs a CT, for instance? And it takes you through those kind of questions before you get to make the referral. And that in itself is both iterative and educational to primary care who may or may not have that knowledge base built in. We're also being able to work with the hospitals in a much better way than before for the same reasons. And then we additionally have an interactive voice response system that can contact patients, and then patients type in numbers, and they can find out exactly about when their appointment is, where it is. And I often describe this as saying that we can track a referral like a FedEx package. We know exactly where it is in the queue. We know exactly the appointment's been made but not done, the appointment's done, and the information has come back about the result. And it's incredibly helpful to be able to track all of that. Auths also are much simpler. For IPA auths, which are, again, only 5 or 10% of the total business in town, we've built the auth into the very system. So once you go through the steps of getting the referral, the auth is automatically sent to the IPA for review and mostly approved because you've already done the questions that we would ask before we approve something. We do not auth referrals as an IPA except out of area. But authing X-rays, advanced imaging, certain procedures has been greatly helped by this process. Again, patient instructions are printed out as the patient walks away. So if they're to stop taking metformin and be NPO and have a creatinine done, all of that is handed to the patient in a written piece of paper at the time that they leave from the PCP appointment. And then again, results are delivered, which I said before. So how is this a solution is a reasonable question. It seems like a lot of work. And when I first began doing this in my own practice, it did seem like a lot of work. But it reduces illegibility. It builds in decision support. There are no lost documents. Having the patient leave the office with legible instructions is incredibly valuable. Asynchronous communication, again, is the key, and I think you'll hear that over and over again about any system that allows providers to interact with each other. And above all, cutting down on these phone call and phone tag that we all do, and then phone calls to patients as well. Closing the loop on referrals is really what gets high results in terms of population and chronic disease management. Not just ordering the mammogram, but actually making sure it's done is very helpful. And then ultimately using this as a tool that educates clinicians about what are the right steps to go through to work up a problem. So the year one results, there are 333 separate users with passwords on the system. You can see who they are here. There have been 417 rules written based on the thing being ordered. There are 38 different queues that are available for scheduling. So far, 4,800 referrals have gone through the system. 300 calls have gone out via the IVR system to patients. Patients seem to really like the IVR system. However, a lot of the offices feel it's impersonal and are asking us not to do it. And then, most excitingly, we've been able to use this for redesigning care. And one of the issues in a private practice environment is how do you build in behavioral health? We now can do everything but urgent referrals to mental health through this system and have promises from them that they look at their queue daily and that for the people in the pilot project for this, they're willing to get patients in who need to be seen right away within 24 hours. It's not quite the warm handoff that happens in the FQHCs with mental health built in, or in some of the, I'm sure some of you out there represent integrated systems that have that. But it's a lot better than the 1-800 carve-out number that we had before. We're also able to refer to chronic disease self-management through the system and use it for our care transitions program for patients going from hospital to back to PCP. And I just wanted to show you some pictures here to show you what it looks like. This is the front page that after you log in, and I'm usually using the submit a referral to specialty or diagnostic. My staff uses other things here. Just showing you what the mental health referral would look like, because I think this is a really exciting development. Here's a patient with depression and anxiety and would like an appointment on a Tuesday afternoon. And so you click on mental health. It then takes you to how old they are and how urgent is the problem. And it defines urgency, and you can see in the blue box. Then you go and what you need to send the clinician, most recent chart notes, med list, allergy list, and copy of insurance. You keep going, and there you have the referral has been made. You can print this out and hand it to the patient, and then they can call up themselves and say, I'm referral number 101060, and find out exactly when it is, where it is, and has it been accepted yet. Really cool stuff. Here's an example for chronic disease self-management. This is a peer-led Kate Lorig model self-management program in our community, and you can refer same way for this. We hope that this up referrals. We're actually doing quite well in regards to referrals for this, but we think that patients walking out with a firm referral is a lot more likely to lead in a patient going than just saying, here's a pamphlet, you might like this. Here's an example of an orthopedic referral where the primary care hears back that the referrals occurred. This one says this referral not accepted, and they say, and the ortho saying, I can't see him fast enough, please refer to somebody else. Then you could go to your queue every day. There's an inbox and see, what's happening to the different referrals that you've made, and you can drill down quite easily. And those are all the slides that I have at this point, so we're ready for questions.
Thanks, Alan. What a great story. And there are questions. The first one is, do the PCPs enter referrals into IRIS themselves? And if so, how long does it take a physician to complete a referral?
So, really good question. And the answer is some. A lot of them still are practicing the way they used to, where they would say, I want a referral for knee pain. and then the staff would do the rest. But then what often would happen is notes would be sent to the specialists that were about the shoulder because there wasn't a lot of engagement. The ones that do use it themselves, and I am one of those clinicians, I would say it doesn't take me longer than to handwrite the form that I had developed in my own office to make a referral, which was just me, free writing what I thought the problem was in the question. I would say about a minute and a half from start to finish for my part of it. Then it goes out to the front desk and they, attach chart notes and documents. We also have scanners in all the practices so they can scan in things if they don't have EHRs to attach, that we call an iris scanner, and it's pretty cool. It really is not much more time. For the EHR practices, that's actually been a harder issue because they're in their system, and most of the EHRs have fairly inadequate documenting ways of making referrals that don't do any of the tracking and communication that we do. So we're figuring out how to allow them to use IRIS, but then to populate the EHR at the same time so they have documentation or referral. And in those practices, we're more likely to get the clinicians to fill out the initial part, which I think is really the value of this, but because they're already into a computer and using it, but also support the fact that DHR has to document such things. So that's where we're at now. I wish everyone used it hands-on because that's where the real value is, and we have to figure out redesign flows within the practices to help support that.
And then another question that came up was if the IPA looked at other systems in addition to IRIS, and why you decided to go with it.
Well, we did look at a number of systems. I was actually not part of the review process, so I don't know exactly what they were. We liked IRIS because it was a rules-based system, and that was what was attractive to us. We were, as an IPA doing auth, very often you get sent an auth without adequate information, and then you end up saying, what about this, what about that? And then you get responses that delay things and are really inefficient. So we figured if we could build in those questions on the front end at the time of the referral, it would save everybody a lot of time. And IRIS is the one that really allowed us to do that. So that's why we went this route, and we've been quite happy with it. But I'm sure there are other really useful products as well. I'm fairly agnostic as to products in general. Anything is better than nothing is what I would say.
And then from the same group, they asked what EMRS does IRIS integrate with?
Well, we have a genius programmer, and I'm not giving his name out to anyone because we don't want him recruited away. But basically, we have it going with Practice Partner, Allscripts, eClinicalWorks, NextGen, I think, is in the works right now, and Epic is in the works. We've not succeeded as a community to only have one EHR. It seems no two practices have chosen the same EHR yet in Humboldt County. And about half of the patients and about 40% of the practices are on EHR currently. But we'll do them all. Our goal is, we think this is actually more valuable than documenting the visit. And so every EHR that comes along, we'll figure out how to get the data back into it from IRIS.
A couple more questions. If health plan guidelines are needed, who obtains that information? And if the request is denied, then how do you get the guidelines? And then the second question is, does IRIS interface with EasyCap?
IRIS does interface with EasyCap because that's our system. The guidelines, we went out and got guidelines for other insurances, but we're unable to automatically submit that as auth. So they still have to do separate auth. We're working to try to make that better, but getting the phone answered at Medi-Cal recently hasn't been so easy, with the budget the way it is. And in the private sector, the blues have not been, outside of the plans that we manage, which are CalCare and which is Blue Cross and Blue Shield HMO for PERS. so far the rules are there, but not the auth doesn't get submitted automatically. For patients that we manage, all of it happens in one set of clicks.
Great. And I think maybe since we have more time for questions, we can return to a few that were for Dr. Chen.
Great.
Let's see. I think one of the questions was, is there ever a formal denial of a request to a specialist, and then what is the communication with specialists like, by phone, email, or only the referral form?
Right. So there is again, we are really fortunate. Just hearing Alan talk about his system makes me realize how fortunate we are, despite our lack of specialists, that in some ways we actually have a much less fragmented system. But we don't actually have prior authorization within our system. So if someone, again, is even someone who is a San Francisco Health Plan patient does not need a prior authorization unless they're going outside of what's offered at San Francisco General Hospital. That was the first part of the question. What was the second part? Sorry, I can't see it here.
The denial. How
do you communicate with phone, email? So you absolutely can call and email people, and in fact, that's why we include all that information in the referrals in auto-populated field, and we actually post all of the specialist reviewers' contact information on the policy page for each clinic. The main reason most people go through the referral form is because it's actually captured in the medical record, and it's actually there for everyone to see. So if you're having a medical or clinical discussion with the specialist reviewer, again, it's very advantageous for anyone to be able to see your reasoning and thought process and the decision-making process for that patient. But absolutely, we have the specialists are also available by phone and email.
Great. And then another question relates to when the referrals are sent back to the PCP, does this ever cause a delay? And at what point do you send extension letters to the patient?
I'm not sure what an extension letter is, but the way the PCP gets notified if it's not scheduled, so we've developed a whole system of notification emails. So when the patient gets scheduled for an appointment, I as the PCP receive an automated email saying your patient, so-and-so whom you referred to endocrinology has been scheduled on this date at this time. You may want to check your work list for additional issues. If it's not scheduled, as soon as it's not scheduled, I get a notification saying this patient has not been scheduled. You are expected to check your work list in order to provide a response to the specialist. If I haven't checked after 2 weeks, I get a reminder email, and that goes on a weekly basis until it gets checked.
And then from the same person, this might be related, but when the request is changed by the specialist and just directs the PCP how to handle the request, do you generate modified letters to the member? Maybe that might be more of the commercial sector model of sending letters.
Right. And actually it's interesting. I know that we've actually worked with LA Care to adapt this model to a system because they do require prior authorization. So they've linked an e-referral model to their prior authorization system, actually. But they're still in the process of ramping up, and I don't know that they actually have data yet in terms of what percentage of patients don't end up seeing a specialist.
Okay.
I had a question for Alice as well. This is Alan again. As a primary care clinician, I find that if I tell a patient I want to make a referral, and then the specialist ends up saying they don't want to see the patient yet, they want me to do some other stuff, that it's very hard to not look bad to the patient at that point. It's sort of a confidence breaker from the patient's side. And it's then very easy to scapegoat the specialist or make the insurance company look bad, or when it's actually something I should have done already. How do you not set patient expectations on a certain result but engage them in the question. We are trying to figure out the best thing to do for you, and I'm going to contact the specialist around a referral, and they'll either give me advice or make a referral. How do you handle that issue where the PCP says to the patient, I'm going to refer you, and then it turns out no referral happens?
Right. I mean, I think one is we probably have a different patient population, although interestingly, with Healthy San Francisco, we actually do have patients coming into our system who are savvier and kind of that direct, self-referral to specialist is more of an issue. But I have exactly the conversation that you just had. So instead of saying I'm going to refer you to the specialist, I'm going to say, you know what, I want to get some advice from my cardiology colleague and my heart specialist colleague, and I'm going to talk to them and see if you need to be seen in clinic or what we need to do. And I found that my patients are perfectly fine because, frankly, a lot of our patients have to take off work to go to additional appointments, and it's a real slog for them. So they would actually, I think particularly for people who either because of geographic distances or frankly because of, again, limited ability to navigate a healthcare bureaucracy, having a medical home and just going to that one-stop shopping is actually something that patients like.
Right. It's interesting, being 5.5 hours away from San Francisco, we send patients to UCSF, usually not the general, but up on Parnassus. And you could drive 5.5 hours each way, so 11 hours plus an overnight stay in the hotel to arrive at an appointment where the specialist has no information about you, and you get 15 minutes of time.
Exactly. And actually, it's our colleagues at UCSF Medical Center have actually been talking to us about trying to adopt a new referral system.
So just if you have that conversation, they need to make that available to the hinterlands.
Okay. Point well taken.
We have another question that was asked earlier for you, Dr. Chen. Sounds like the UCSF specialty clinic gets to opt into the e-referral system, or in other words, not all clinics are on the UCSF e-referral system. So do you have a dual referral system, and does this cause problems for the overall?
Yes and yes. Although what's interesting is that with really only one exception, all of the clinics would like to be on e-referral. So the main limiting factor is finding a specialist reviewer who is willing to review within the time frame that we say. So we say that the reviewer has to respond to the referring provider within 72 hours, and that within 5 days the PCP receives a response. Because if it's scheduled, it takes an additional 1 or 2 days for it to go through the clerical staff. But if it's not scheduled, you're supposed to get a response within 72 hours. So that's actually been the main limiting factor. Most specialties want to be on it, and it's a matter of identifying the specialty reviewer and also for the e-referral team, working with them and the IT staff working with them to customize a referral portal for them, to have some referral guidelines and get everything they need. But it is, anytime you have a dual system, it absolutely causes more workarounds because then you have to check a list to see what clinics are on e-referral. At this point, what's nice is the majority of clinics are on e-referral, so it's actually the exception to the rule not to be on e-referral. We have about 30 clinics and services, including CT, MRI, and ultrasound, which has actually been a fascinating thing because as a PCP, I feel like in some ways that's the place where I know the least, like whether actually an MRI is indicated when I should be getting, when I'm ordering a CT or an ultrasound would suffice. And so we have a nurse practitioner reviewer on that, and they've actually been able to actually even forestall some or just prevent some CTs and MRIs, which is a huge, I mean, when you talk about bending the cost curve, because what they'll do is they'll look at old studies and they'll look at the referring question and they'll say, well, what will this study actually tell you? So they're actually putting in some clinical judgment. Again, I think the incentives in the fee-for-service sector are just not there to do that kind of preventing unnecessary testing, but I think it has potential.
Great. And then just a couple, I think, quick questions. One is for Alan about, does IRIS integrate to GE Centricity Business Solutions, formerly IDX?
no one has that in our county, so not as of yet, but it could easily be done. These are not hard. The programming apparently is quite simple, and it's a few hours work per EHR for our programmer.
And then there's another question: what criteria is used as standard scientific criteria? I'm assuming that refers to the rules.
Well, it's a mixture of things. Some of them are, and because we were trying to engage all the specialists in the community, and that's actually been really successful, they got to say what they wanted, except for the cases that we manage. And even there they get to say what they wanted, but the rules that we have as a delegated group tend to come down. They were either generated internally, but the great majority of them come from the health plans, and they have to go through DMHC approval. So they tend to be very specific around certain tests, and most of you in the commercial world have dealt with the imaging guidelines used by the Blues, and they're very, very specific, and we just embedded that in there. And they are relatively evidence-based. It's better than nothing. But let me just, a quick example would be, someone with hypothyroidism and a slightly enlarged thyroid gland, and it's a little bumpy, and so someone would want to order a thyroid scan who was trained 25 years ago. Well, it turns out thyroid scans don't have a lot of role in hypothyroidism anymore. If you feel a bump, you should either ultrasound it serially or biopsy it with a fine needle. And the hot and cold nodule stuff just doesn't matter. So we built that rule in. And now they go in and try to order that test, and it tells them, no, it's not the right test, do this instead. So that's an example of using literature, and that comes out of Disease of the Thyroid by Francis Greenspan up at UCSF. And we embed that guideline in the tool for ordering thyroid scans. And you hopefully, if you've done it 2 or 3 times, you stop ordering them for the wrong thing. That's our hope. I don't have any evidence that it's changed thinking. I just think it will in the long run.
I realize that we're past the bottom of the hour, so I want to thank Drs. Chen and Glasseroff so much for sharing about eReferral and IRIS, and thank you to all the participants for joining. We will send the links to the recording and PDF of the slides later today, and feel free to contact me or Drs. Chen and Glasseroff directly with additional questions. Their email addresses were on the first page of their presentation. And then stay tuned for next month's CIN webinar, which will be